Good day to everyone. Welcome to our highly anticipated webinar. This would be, I think, our 7th series in the year. It's the Women in Neurosurgery ACNS webinar, and we are very happy to have everyone here. I'd like to welcome Prof. Kato.
Yes, thank you.
And then Prof. 𝒂𝒏. Thank you so much for agreeing to chair this session. Our discussants, I'm not sure they have not joined in yet. So today we have two discussants. Professor 𝒂𝒊𝒏 𝒂𝒏, he's from Zimbabwe, and also Professor Kento Sasaki from Japan. So I hope they can join us soon. And we have three excellent speakers today. We hope that they will give us a lot to discuss. So I think without much time, I will introduce our first speaker, Dr. Alejandra Jaume. She's from staff of neurosurgery from the medical hospital in Uruguay. And today she will speak to us on intracranial mycotic aneurysms. All right.
Thank you.
Yes. Can you go ahead and share your screen?
Yes.
Okay, we can see your screen.
Can you see?
Yes, we can. Thank you.
Okay. Okay. Can you see full screen?
Yes. Yeah, now we can see it. Good.
Perfect. Can you hear me also, okay?
Yes, clear.
Yes.
Okay. My idea today is about intracranial mycotic aneurysm. Sorry. What is our experience? Two cases in the last year. The first case is a female, 66 years old, without past medical records. In May, he began with pain in the poacio, dysuria, nausea, and vomiting. Urocultivo evidence 𝒔𝒂𝒏𝒂𝒂, antibiotic is started. Ultrasound report nephritis of the kidneys. She installed intense holocranial headache, evaluation for ophthalmology revealed vitritis with right chorioretinitis. Discharge is granted, and 3 days after giving persist of symptoms and she reconsultation. On examination, patient lose without folk neurological F deficit, hemodynamical stable, febrile records with leukocytosis and ACT performed. Here you can see the CT and MRI showing the subarachnoid hemorrhage in the frontal and ischemic. And here you can see the first cerebral angiogram showing a mycotic aneurysm. Here in the angiogram is the frontal branch, and here distal the mycotic aneurysm with vasospasm 2 and the very, very distal vas. What we think, subacute endocarditis with a typical presentation without heart failure, mycotic aneurysm in the right MCA complicated with hemorrhage and local regional vasospasm and embolic phenomena, renal embolism, and some Wells bladder hemorrhage. What to do? Antibiotic treatment and follow-up, open surgery, cold treatment, flow diverter, stent and cold, and vasocclusion. And we decide antibiotic treatment and follow-up because the aneurysm is very distal in the cerebral media, and I don't flow diverter in this moment. And after days, she installed depression confusion and right iriacy developer, and you can see the large hemorrhage in the frontal, and she died. Then the case 2, May, 62 years old, make a record resection of polyps in 2016, smoker, 3 weeks of evolution of fever without source, interpreted as prostatitis and medicated with antibiotic, 11 days of treatment with persistent fever. On the day of admission, he presented aphasia and of expression lasting approximately 30 minutes, and that regressed spontaneous. Blue culture developed 𝒔𝒑𝒂𝒄 bovis. Here you can see MRI with showing subarachnoid hemorrhage and left parietal ischemic. Here. in the parietal, and the first cerebral angiography showing wide irregularity in the left branch parietal. What do we think? Infected endocarditis without heart failure, irregularity of the left parietal artery, probably inflammatory phenomenon due to the infected embolus, complicated with 𝒂 hemorrhagia and ischemic. What do you do? What do you? Antibiotic treatment and follow-up, treatment for vascular occlusion. And we decide antibiotic treatment and follow-up because without the mycotic aneurysm now. The second cerebral angiography a week later showing evidence of the formation of mycotic aneurysm. You can see here. The first cerebral angiography showing irregularity alone, and the second cerebral angiography showing the intracranial mycotic 1 week after. And what do you do? Antibiotic treatment and follow-up, upper surgical treatment, flow diverter, stent occlusion, and basal occlusion. And we decide basal occlusion. Here you can see the treatment endovascular embolization with perfect when chaperone, MASHI, hybrid, and NSVA. Here you can see NSVA 50%. And here you can see the 7% occlusion was evidence with hyperfusion area where he had a ischemia previously. And here you can see the good recovery of the patient to CT showing without complication, and the patient recovery all. You can see the patient speaking Spanish without aphasia, and he had a good recovery, MRA 1. What did we learn from our experience? One patient without endovascular treatment died, and we patient with endovascular treatment got recovery. For that, our conclusion, the mycotic gallus is a rare entity. They contributed to a 5 of the neurological complication in patients with effective endocarditis, and we had intracranial mycotic aneurysm rupture. There are to do treatment, endoval treatment or directed surgery. But when the aneurysm are ruptured, there are to do treatment with surgery or endovascular treatment, or we are antibiotic treatment and follow-up for imaging and the 7 and 15 days. My ask for you if the Basilar could not be significant, what will be the treatment of choice for this case? Thank you.
Thank you very much, Alejandra. That was a very simple and good presentation. You've left us with a few questions to answer, I guess. So maybe we'll start with Professor Kalangu, are you around? Or Professor Sasaki? If
both of them are absent.
Absent. Okay, so then maybe
yes.
Professor Goel, would you like to comment? I'm sure you have some.
Mycotic aneurysms are difficult issues. Because they are difficult, because they are peripheral, very peripheral. They are not in the main vessel, they are in the peripheral vessel. Second problem is they are not round and smooth, they are irregular kind of thing. And they are quite rare. And they can come with bleed, as we have seen, the patient bled to death. So they can come with bleed, they are small aneurysms, they are irregular aneurysms, they are peripheral aneurysms. So the best thing is to occlude them. Whenever we diagnose a mycotic aneurysm, it is better to occlude. Considering that they are very rare clinical entities, they are not very common, and they can be in the depth, like in the Sylvian fissure, in the corner of the Sylvian fissure, in the like a DACA aneurysm. So these aneurysms are difficult to treat surgically also. So if the coils and if endovascular treatment can be done, it is the best, and many people are showing that endovascular treatment is a good form of treatment. As far as the incidence of mycotic aneurysms are concerned, Like when we talk of infections, we talk of India. And India, there are all kinds of infection, whether it is tuberculosis, whether it is fungal, whether it is what kind of infection. But even in India, we do not see mycotic aneurysms very frequently. And mycotic does not mean mycosis means fungus. It is not actually fungus, it is infection. So infective origin, irregular configuration, distal location, very small size, very peripheral, makes these aneurysms a difficult clinical entity. And many people are nowadays showing endovascular treatment. I think that treatment is here to stay, and it is the future of treatment. Sharon.
Yes, I agree.
Okay. Would anyone like to comment? Anyone
Sharon?
else?
No, Sharon, maybe
Yes.
I think Professor Ishihara Sensei
Yeah,
is
that's right.
one of the best endovascular neurosurgeons in Japan. So maybe we can ask him.
Yes, so Prof. Ishihara, I saw him. Would you like to give a comment?
Yes, actually, I have several experience of infectious intracranial aneurysms. As Professor Goel said, infectious intracranial aneurysm is very easy to breed. And the problem is first, we can control the infection or not. And first, of course, we start antibiotics, and we have to check small aneurysms. Maybe you checked aneurysm by DSA, 3D angiography, and actually it is very difficult to detect small aneurysm. So we usually use gadolinium enhanced MRI, and also we check DSA, and if we find out aneurysm, for example, the first case, it is hemorrhagic concept, so we try to occlude, but usually we use coil but usually we can't preserve the this artery flow. We have to occlude parent artery.
Thank you so much for your comment. Just I want to ask, because you mentioned about the vessel wall enhancement, something like that. So that means is some aneurysm, the wall must be very fragile.
Yes.
Then enhancement is just some the detect of that the aneurysm. Usually, usually not only one, maybe the multiple, because of the fungus. That means it's not only one. Yes.
I think so.
Then usually you occlude the main vessel, parent vessel.
Yes, we have to occlude parent artery usually.
Thanks so much. So one more question, because you are endovascular teacher. So the aneurysm itself, the shoot aneurysm, when you put the coil, where you are the coiling?
Coil is very safe. For example, the presenter used 50% NBCA. It is good, but sometimes difficult, because NVCA penetrate to distal artery, and maybe it is a little bit difficult to control the occlusion site. You see.
Sensei, Daichao Sensei is from the Yamaguchi University, the chairman.
Very good, very good. So these aneurysms are very fragile, right? Very fragile, like bubble aneurysm, like Ogawa's aneurysm, small blister aneurysm. Are they like blister aneurysm, very fragile or not?
Very fragile, I think.
I've experienced mycotic aneurysms which were giant, and the youngest we got was actually a 8-month or 9-month-old baby, but it was a big giant at the M4.
Is it fungal aneurysm?
It's not fungal. It's
bacterial.
You mean fungal as it looks like fungal, or is it? It was not fungal. It was bacterial.
Bacterial.
He had a heart. I think he had a heart. Yes, correct. But it was a giant. So that one we excised. Actually, we excised the. Yeah, we have a question from Biswas. Yes, Biswas, you want to ask your question?
Yeah, Sensei, thank you for the opportunity. It's a very fresh case presentation I have heard about the mycotic aneurysm. So a couple of questions, if you permit. First question is, what are the points from the angiographic aspect I should consider for the endovascular treatment of the mycotic aneurysm? And number two, if the parent artery cannot be saved, is there any role of bypass? And last question, as we have an endovascular neurosurgeon here, so in case of peripherally placed mycotic aneurysm, what should be the distal access catheter for coil occlusion or embolization?
Me?
Yeah.
So you're asking Ishan Sensei or
if you have to occlude proximal site of the artery, large vessels, maybe you have to consider the bypass surgery. And for peripheral region, we use marathon catheter.
Marathon. Okay. I mean, no problem with navigation. I mean, it doesn't create any injury to the already implanted vessel.
And of course, for peripheral aneurysm, I also use NVCA.
Let me see. Okay. And what are the angiographic architecture you consider to go for the endovascular treatment?
Oh,
I mean the catheter angiogram. I mean the DSA findings. Do you consider the CFT or something else before taking decision?
Yes, of course. We use 3D angiography. Yes. You mean craniotomy or endovascular?
Oh yeah, craniotomy or endovascular, exactly.
How do you think? I believe endovascular is better than craniotomy for infectious intracranial aneurysm, because aneurysm is very fragile. So craniotomy, sometimes it is difficult to find out the aneurysm, and when start bleeding, it must be difficult to manage it, I guess.
Okay. Thank you, Sensei. Thank you.
Is there any other questions from the floor? Okay. Any comments? So thank you so much, Alejandra. I think we really enjoyed it, your presentation today. Thank you for presenting to us the different types of management and care for patients. I think we can move on to our second speaker. Our second speaker today is a friend of mine, and also I think everyone knows her. She's our Education Committee and she's our secretary. So I'd like to present Professor Abida Shah. She's Assistant Professor of Neurosurgery in St. J.S. Medical College and Chem Hospital, Mumbai, India. And today she's going to talk to us about management of basilar invagination, the history and the future. So, Abida.
Hi, Sharon. You can hear me?
Yes, can hear you.
Okay. So today I'm going to be talking on basilar invagination. I'll give you a little bit of the history, and the person who has changed the management of basilar invagination is the chair of this webinar. So I will show you what the changes have occurred over the years and what we expect the future to be for this entity. So basilar invagination was an unknown entity, and it was just a radiological entity. No one knew what it was. The first accounts of basilar invagination was found by Ackermann in cretins in the 1790s. Only later, 𝑦𝒏𝒆𝒆 in about 1855, they coined this term, impressio-basseous cranii. First, it was thought to be a disease of cretins, but obviously later on it was known that that is not true. And then later on in 1857, Virchow coined the term platybasia, and he found a big association with basilar invagination and platybasia. And they used the terms platybasia and basilar invagination interchangeably for a long, long time. So basically, platybasia is flat. This angle is very flat, as you can see that I have drawn here. And basilar invagination, I will define it as we go further. So this is how it is. Platybasia is an abnormal flattening of the base of the skull, and basilar invagination is actually a prolapse of the vertebral column into the skull base. So there are two types of basilar invagination. One is when this odontoid crosses this Wackenheim's line and also the Chamberlain's line. And there is another one where the basilar invagination, the odontoid will cross the Chamberlain's line, but it does not cross the Wackenheim's line. So these are the two types of basilar invagination, and associated, you may or you may not have platybasia. Of course, in this type of basilar invagination, it is generally platybasia is associated. So if you see this image, this is a drawing from Homen of showing the interior of the skull after removal of the brain. It is a case of basilar impression, and you can see how there is a cephalic bulge of the clivus here, and apparently this is what they used to call it, the stenosis of foramen magnum, because of the push or the prolapse of the vertebral column into the skull base. So then later on, what happened? Chamberlain developed an interest in this entity, and this is how he described it. It is thought as if the weight of the head has caused the ears to approach the shoulders, while the cervical spine, refused to be shortened, has pushed the floor of the posterior fossa upward into the brain space. So even till 1911, the basilar invagination was diagnosed radiologically, but still nobody knew what to do about it. It remained anatomic and radiological curiosities. So you can see this statement. The American literature is singularly lacking in reference to basilar impression, though a few references have been made to a somewhat related type of anomalous development, the so-called Klippel-Field syndrome. So earlier, these patients used to obviously present with short head, with quadriparesis, with neck pain. So the earlier treatment that was advised by Chamberlain, two patients, one was treated with a suboccipital decompression, both were treated with a suboccipital decompression and upper cervical laminectomy. One of the patients survived and one did not survive. So this entity remained an enigma, and people used to have varying treatments for this entity, and mostly the treatment was decompression. The results were variable and the associated morbidity and mortality was very high. So obviously this decompression was not a solution for basilar invagination. So we in our Institute of KEM Hospital have a lot of craniovertebral anomalies, and this was a paper published from our institute in 1964 by Dr. Bharucha and Dr. Dastur. where they have said that it has only recently emerged from the realm of anatomical curiosities into the more practical field of clinical neurology. And this is when the changes started happening and where a lot of basilar invagination was studied and then the treatment was designed. So let's see the events that happened. So in 1987, Professor Goel described this technique, plate and screw fixation for atlantoaxial subluxation. So this was the beginning of a change. What was the technique? The technique involved opening of the C1, C2 joint, denuding of the articular cartilage, stuffing of this joint with bone chips, and then later on putting screws through C1 and C2. So C1 lateral mass and C2 pedicle screws. So as you can see, this is his first patient that was done. And this was the construct, the metallic construct that was used. So this changed the treatment of atlantoaxial fixation, where many other not many good methods of stabilization were present at that time. This one actually changed the method of stabilization of atlantoaxial instability. Then what happened in 1998, studying this basilar invagination, this was the first paper that was published by Professor Goel based on a surgery based on 190 patients, in which basilar invagination was divided into two groups based on the presence or absence of Chiari formation. So even at this time, what was advised was, for this one, group 1 basilar invagination, a transoral procedure was advised. If necessary, it was combined with a posterior fixation. And for group 2, with basilar invagination with Chiari, only a foramen magnum decompression was advised. So this was the treatment modality. And as was noted, the morbidity of even doing this decompression continued to be high. So as the understanding evolved, this was another landmark paper in 2005, where using the method of opening the joint, distracting the joint, and fixing it, a reduction of so-called fixed atlantoaxial dislocation was achieved. So by the end of this experience, it was realized that there is nothing like fixed atlantoaxial dislocation. It is a mobile dislocation. And by manipulating the joints, you can actually realign it and open the joints and reduce the dislocation. So if you can see this example, this was in flexion and extension, no movement. This was considered to be a fixed anomaly. But as you can see here, by intraoperative manipulation of the joints, the atlantoaxial instability has been reduced. And this is the fixation construct. This is again another patient with a fixed atlantoaxial dislocation. And you can see the alignment after surgery. Again, another patient. So as this was realized that there is nothing like fixed atlantoaxial dislocation, simultaneously the understanding of basilar invagination evolved. And in a paper in 2004, Professor Goel changed his classification of basilar invagination, which was based on Chiari formation. And now it was based on this odontoid process. So group A or type A was where the odontoid process crossed the Wackenheim's line along with the Chamberlain's line. And type B was where the odontoid process remained beneath the Wackenheim's line, but crossed the Chamberlain's line. And you can see the associated platybasia. So the treatment for type A basilar invagination was atlantoaxial realignment, craniovertebral realignment and fixation. And this understanding revolutionized the treatment of basilar invagination. It was realized that these joints, they are abnormally inclined. They are not fixed. They are mobile or hypermobile. And the problem in basilar invagination is mechanical instability. And the treatment involved opening of the joints and realigning them and fixing the craniovertebral junction. So it was realized that basilar invagination is a disease of the atlantoaxial joint. Basilar invagination is a dynamic and progressive process. It is due to the increasing slippage of atlas over the axis over a period. And this process of slippage may be exacerbated by trauma. It was likened to this term, transatlantic odonto-occipital listhesis. It was likened to lumbar spondylolisthesis, and this was basilar invagination. And this was the cover page in Journal of Neurosurgery in 2005. And now I'll show you some examples of this type A basilar invagination, which was reduced by craniovertebral distraction, realignment, and fixation. So you can see this type A reduced without any decompression, just by doing fixation. Again, another case, you can see the reduction. See the joints. See how abnormally inclined here. Here, It is almost as if the atlas is fallen over in front of the axis. This is again another patient, and you can see how with just maneuvering the joints, you can bring down the odontoid process, realign it, and fix the area. This fixation actually caused a remarkable clinical recovery in the patients in the immediate post-operative period, and it was sustained for a long, long time. Even where there was, these abnormal things, C1, C2 fixation could be performed. You can see again in this joint that the joint is actually vertically inclined. But if you learn the art of opening the joint and getting into it and putting bone chips into it and fixing it, you can actually do a beautiful job for treating this basilar invagination. Here you can see how the odontoid has come down. So these are many examples. I will just quickly show them. All of them, you can see even associated with Chiari and syringomyelia. You don't need to do anything to this. You don't need to do a posterior fossa decompression. All you have to do is open the joint and realign them and fix it. As our understanding has evolved, it is even realized now that even the realignment, it might not be a complete realignment. As long as you fix this area, it is the instability that is the problem, and fixation is the most important step in treating these patients of basilar invagination. So while doing these cases, we saw that there was a reversal of a lot of musculoskeletal changes. So this patient with torticollis, this is in the immediate post-operative period. You can see that the neck has lengthened and the torticollis has straightened up, and the patient has done well. These are soft tissue anomalies in patients with basilar invagination. You can see the Chiari and the syrinx, and this is the patient. The MRI was done 48 hours of the surgery. You can see that the Chiari has gone up and the syrinx has resolved just with an atlantoaxial fixation. Again, another patient, this is a delayed image, and you can see how beautifully the syringomyelia has actually resolved. And here you can see the basilar invagination treated only by a C1, C2 fixation. So this was our large experience on group A, type A basilar invaginations that we published some time back. Sometimes these patients have difficult anatomy. It is difficult to understand the relation of the vertebral artery and the relation of the joints. So we published this for the first time, where we made 3-dimensional models for patients with complex craniovertebral anomalies and used them during surgery to keep them at our side, which can guide the surgery. So here you can see in this patient, the vertebral artery is abnormally coursing over the C1 lateral mass. And here you can modify your strategy so that you can actually do a fixation. Here you can see on one side, we have put a C1, C2 screws, and the other side, we actually used a spacer where the vertebral artery was. This is again another patient with an anomalous vertebral artery. And you can see how lifelike the 3D model is. Here you can see on one side, we have done a C1, C2 fixation. On the other side, we've just put this spacer. So here you can see how the basilar invagination has been reduced quite nicely. Again, so you can see how, when you cannot sometimes imagine it, this gives you a very good 3D perspective where you can see that the anatomy is abnormal. The vertebral arteries are actually running here, and then you cannot make a mistake while passing your screws. So the key in understanding basilar invagination is this C1 and C2 bones, and the whole point is playing with this joint, the C1, C2 joint. And the most important points while doing this surgery is, one is to take care of the vertebral artery, and one is to take care of the venous plexuses in the region. So craniovertebral junction instability revolves around not the odontoid process, but the C1, C2 joints. And if you make mastery in this, understanding this anatomy and doing this surgery, you will be effective in doing a very good surgery of C1, C2 fixation. So here you see this is the C2 bone, which is an atypical bone. This is the superior facet. This is the inferior facet. You can see they're not in line. And here you see that the vertebral artery is coursing within the superior facet. So one of the problems with this surgery is if there is a high riding vertebral artery. But of course, we have Professor Goel has described mobilization of the vertebral artery. So here you can see this is how the vertebral artery groove runs, and not in this case, but sometimes you can have difficulty while performing this surgery. I think I'll show this video only if I have time later, but this is the technique of C1, C2 fixation. And apart from C1, C2 fixation, there are many modifications that he has described. Here you can see that the C2 screw is going both to C2 and C1. So this is a double insurance atlantoaxial fixation. In this, the screw was directed inferiorly. Sometimes, the pedicle is narrow, the pedicle may be broken. You can direct your screw inferiorly towards the C2-3 joint. And this is also a very stable construct. Sometimes you can just use standalone spacers into the C1, C2 joint if you are having problems inserting screws. We don't use these spacers much now, but this is just an option that you can have. And this is another option, that is transcranial insertion of atlas facetal screws. This is for very high basilar invagination. So now we have come to a point where we are treating type A basilar invagination with craniovertebral realignment and C1, C2 fixation. Now the understanding of basilar invagination progressed further, and we started looking at the facets. And here you can see Professor Goel divided these facets into this facetal dislocation into 3 types. So this was type A, where the facet of atlas is over the facet of axis. This is typically seen in group type A basilar invagination or in acute instability. So this is type B, where there's Chiari syringomyelia, and here you see that the odontoid is not crossing the Wackenheim's line. Here you see this facet. It is actually going posteriorly. This is type 2 facetal instability, or type B. And the third type is where there is Chiari, where there is syringomyelia, not this patient, another one, where the facets are actually in alignment. This is also type 2. And this is the types of facetal alignment that have been classified by us. And based on this understanding, we realized that basilar invagination, Chiari formation, and syringomyelia are all a continuum of the problems of atlantoaxial instability. And a lot of these things have now been labeled by us as central atlantoaxial instability. So type 2 and type 3, where the facet is actually posterior to the facet of axis, or the facets are in alignment, they are called as central or axial atlantoaxial instability. So this was group A. Then we came to group B. Now, if you remember earlier, this was treated by foramen magnum decompression. So as the understanding evolved again, it was realized that this is not tight posterior fossa. This was also described first by Professor Goel. The problem is here. The problem is in the joints. And the problem is atlantoaxial instability. And if you just treat this instability, you will reverse the neurological findings and the radiological findings of all of these patients. So you see this patient, this is flexion and extension. There is no change in the atlantodental interval. There is no facetal malalignment. This is type C. And what have we done? We have just done a C1, C2 fixation. There is no posterior fossa decompression. And you see the result, radiological result after some months of surgery, but clinical result is immediately that the patient improved in the immediate post-operative period and is doing well till now. And here you see that the syrinx has actually halved in size. Many of times the syrinx actually disappears. So this is again another case patient with type B basilar invagination. And here you can see treated with C1, C2 fixation. She's actually a dentist in a medical college and she's doing very well. It is now about 6 years after surgery. This again another patient with Chiari and syringomyelia. You can see how high the group B basilar invagination is. This is the Chamberlain's line. The odontoid has gone up. There is some amount of platybasia. Here you see the type 2 facetal instability, and this is just after fixation. The Chiari has gone up, the syrinx has reduced. Similarly, there are many examples now of type B basilar invagination, and you can see the post-operative radiological, and immediately you will see the clinical outcome of these patients. So the understanding evolved to realize that all basilar invagination is related to atlantoaxial instability. And the whole treatment of this basilar invagination has now changed from the era of decompression to the era of decompression and fixation to the era of craniovertebral realignment and only fixation. And now the most important point is that it is the atlantoaxial fixation that is important. Craniovertebral realignment will come, but if you don't have to go and aim for a complete craniovertebral realignment. And what did this mean for transoral surgery? It has become historical. For basilar invagination, transoral surgery is historical, and there is no indication right now for transoral surgery. Now we have seen basilar invagination. The next important thing that comes in this region of the craniovertebral junction is Chiari formation. And this was the paper published in 2015. The initial paper where we analyzed 65 patients with Chiari formation treated by atlantoaxial instability. And later on, we increased our experience, and this with 388 surgically treated patients with Chiari. And the Chiari is just an adaptive phenomenon to atlantoaxial instability. The syringomyelia, the Chiari, they are all protective mechanisms that come in the face of atlantoaxial instability, and the problem is in the atlantoaxial joint. It is important to realize this. So these are just neural markers. The Chiari, the syrinx, they are neural markers of atlantoaxial instability. Sometimes the facets show malalignment, sometimes the facets do not show malalignment. So the treatment for this remains C1, C2 fixation. There is no need for any posterior fossa decompression. And you can see this post-operative that the Chiari has resolved and the syrinx has also resolved. So you can see now we have many examples. Here you see there is only Chiari, there is no basilar invagination. The facets are very just mildly malaligned. Treated by fixation, you can see resolution of the Chiari and the syringomyelia. Again, another patient, resolution of the Chiari and the syringomyelia, just treated with atlantoaxial fixation. Here you can see how there is nothing. The atlantodental interval is normal. The facets are in alignment. Just treated with atlantoaxial fixation. See the Chiari, see the syrinx that has completely nearly resolved in a very dramatic manner. And more importantly, the patient does clinically well in the immediate post-operative period, which is sustained for a long, for completely, he gets a new life. So this is again type 2. You can see how the Chiari and the syrinx has reduced. Many examples here, you can see that the syrinx has actually completely gone. You see there is no basilar, there is Chiari and syrinx, the facets are in alignment, treated just with a C1, C2 fixation. So this was extended because a lot of people, you had queries that, this might work in adults, not in pediatric age group. So we analyzed our experience in this pediatric age group and we found the same kind of results, that the patients did well in even patients with no craniovertebral bone anomaly, just Chiari. What happens when patients have failed foramen magnum decompression? So a lot of our patients we had treated earlier with foramen magnum decompression have come back to us, and we have treated these patients with C1, C2 fixation, and they have done very well after this second surgery, where they had started deteriorating after the first surgery after an initial improvement. So here you see the syrinx, and here you can see post-operatively the syrinx has gone. Again, another patient treated with, foramen magnum decompression, this shunt, you can see syringo subarachnoid shunt that is present. And here you can see the patient continued to clinically worsen, and we treated with C1, C2 fixation, and you can see that the syrinx has practically resolved. So this was the paper on failed foramen magnum decompression. Again, we used a lot of MEPs to analyze what is happening after we do the craniovertebral fixation or the atlantoaxial fixation. And we found this, that the MEPs, you see this mark and see this, the MEPs actually increased by 30 to 40% as soon as we tightened the screws on both sides without doing just a decompression. And this rendered more credence to our hypothesis that atlantoaxial instability is indeed the cause of Chiari formation and even group B basilar invagination. Here you can see that the MEPs have increased in intensity, and of course the patient did well. This was our paper on the subject. So basically basilar invagination, syringomyelia, and Chiari formation are all a gamut of malformations of the craniovertebral junction whose main cause is atlantoaxial instability, and realizing that will actually change your whole management of these entities. Even patients with idiopathic syrinx who present with classical spastic quadriparesis, if you do not have any other cause, you look at the craniovertebral junction. Even patients with kyphoscoliosis, scoliosis, you look at the craniovertebral junction and you see this fixation that we have performed, you can see that the syringomyelia is actually disappeared. Again, another patient with just syringomyelia doing very well with just atlantoaxial fixation. Again, another patient with idiopathic syrinx, no other problem, presenting classically with spastic quadriparesis. And here you can see the atlantoaxial fixation, and you can see that the syrinx has resolved. So basically, basilar invagination, syringomyelia, and Chiari formation, atlantoaxial instability is the cause. They are nature's adaptive formations to stall and delay the effects of instability. Chiari is like an airbag, which comes into play when there is atlantoaxial instability. It comes in to protect your cord from that subtle instability. And realizing this is important. And all this is finally going to lead to this, that foramen magnum decompression surgery will become historical in the treatment of group B basilar invagination, in the treatment of Chiari formation, and atlantoaxial instability is here to stay. And this is our latest paper on this subject, where we have analyzed our patients with central or axial atlantoaxial dislocation, a review of 393 patients over 12 years. And all these things are actually associated or linked to chronic atlantoaxial instability. So kyphos scoliosis, torticollis, bifid, os-odontoideum, even short head, short neck, basilar invagination, external syringomyelia, external syringobulbia, Chiari, C2-3 fusions, Klippel-Feil platybasia, and even some subaxial problems like subaxial cervical spondylosis, OPLL, Hirayama disease. They all have a component of chronic atlantoaxial instability, and it is important to recognize it to treat these patients. This is how we have divided central axial atlantoaxial instability in the paper, and people who are interested can read this further. And this is the future of treatment of basilar invagination, Chiari, and syringomyelia is atlantoaxial stabilization. Occipital fixation is, of course, never necessary. Foramen magnum decompression is counterproductive, and your patients will come back after many years and will actually come back with worsening. And transoral and transnasal decompression, so decompressive surgery are historical. Thank you very much.
Thank you very much, Habida. Thank you for presentation. Revolutionizing the treatment of basilar invagination, Chiari malformation and syringomyelia. I think a lot of us face this problem in our practice, and we should thank Habida and especially Prof. Atul for coming up, with this theory, this revolutionizing concept. Prof, first of all, if anyone, I think Prof. Ishihara, would you like to ask any questions? I know.
I'm not familiar with this area, but I was very surprised you have so much cases of bradycardia. The incidence is different from Japan because I have not see this disease in our institute.
Maybe basilar invagination you might have not seen, which is a little more common in some areas. But Chiari, of course, you must be seeing a lot.
Yes.
Okay, please go ahead.
Yes, we have some Chiari cases, but maybe you have so many population. Maybe the cases concentrate to your institute.
Yeah, we do have a lot of patients referred to our institute.
Thank you, Habida. Great presentation. Thank you very much. So maybe we may have some incidental such kind of atlantoaxial instability, maybe chronic stage. I think we should make some X-ray something for that case. How do you think? Because we have so many screening in Japan, it's getting popular. So maybe short neck or some.
Maybe short neck, torticollis, and some even kyphos scoliosis. Yes, you should probably do screening. They have very typical features of craniovertebral anomaly. Many pointers, even from external appearance, that you can think about a craniovertebral junction problem.
The thing is, Yoko,
yeah,
atlantoaxial instability, atlantoaxial joint is the most mobile joint of the whole spine, most mobile. Atlantoaxial instability is the most common spinal instability. Atlantoaxial instability is not understood and neglected. Even in Japan, considering Japanese population is going very old, you get 80 years, 90 years, 100 years people. Degeneration of craniovertebral junction have atlantoaxial instability. And treatment of atlantoaxial instability in elderly people, which is neglected in the world and in Japan. If you treat atlantoaxial instability for degenerative spine in elderly people, 85-year and 90-year-old people, you can have very beautiful clinical outcome. And the issue is atlantoaxial instability is a very huge phenomenon. And one is acute atlantoaxial instability when you get injury. and one is chronic atlantoaxial instability. Now you are asking a question, why in India so many patients? You see, in India, I have speculated why in India there are more patients. You know, the injury occurs when the child is delivered from mother. You know, in India, many forceps, they use forceps delivery for the head. They put forceps and pull the baby. So my argument was this injury occurs at that time in India in rural population, particularly in rural population. Like in a more advanced country, we immediately do cesarean section. But here in India and in other countries, they do forceps delivery. And that forceps delivery may be one very important reason for injury to the craniovertebral junction. And also protein-calorie malnutrition can be one important cause. And then this instability is for a long period of time, instability for 15 years, 20 years, 30 years. And in 30 years or 20 years, there are lots of natural protection, like shortening of neck, torticollis, basilar invagination, Chiari malformation. All these things are secondary to chronic atlantoaxial instability. The understanding of the fact that these are not embryological problems. They are not embryological, some gene problem or genetic problem, or it is not genetic problem. It is instability. It is a mechanical problem. Understanding that you can do fixation and you can give new life is a very huge thing for many of these patients. And this is being, in various countries. It is not basilar invagination, is also in many other countries of the world. In US, in China, there is a lot of basilar invagination and syringomyelia. Chiari malformation, of course, is all over the world. There is a Chiari Foundation in Beijing. There is a Chiari Foundation in London, in Birmingham. There is a Chiari Foundation in in Chicago. There are many. Chiari is a very common thing, and Chiari is treated by decompression all over the world. It should not be treated by decompression, atlantoaxial fixation. It is a complete revolution in the field of craniovertebral junction.
So treated by neurosurgeon or orthopedician?
Basically, craniovertebral junction, many people treat, many orthopedic people also treat. But many neurosurgeons also treat. Like in China, there are many neurosurgeons and orthopedic. In Korea, many orthopedic. In Japan, I think many, I don't know about Japan, but many neurosurgeons in Japan are doing quite good craniovertebral junction surgery. I know.
Maybe we can take X-ray.
So this craniovertebral junction instability has to be understood and has to be treated very nicely. Because if you treat nicely, you give new life to the patients.
Thank you very much, the Goyle and Avitashan, for your great contribution. Thank you very much. Congratulations.
Thank you.
Sharon? So one is Annie. Someone is asking.
Yeah, I have.
Yes, please. Go ahead.
Thank you so much for presentation. And
identify yourself, please.
Yes, I'm the neurosurgeon from Ukraine. My name is Kirilo, and I'm now at the fellowship in the Japan for Professor Yokokato. And I have because I'm with you today, and I have some questions, and probably after your presentation, we should send all of our cases to you for treating from Ukraine, because the results is so beautiful. Thank you so much. I work in the pediatric department and adult. And also in Ukraine, we have so much cases, the Chiari. And probably all those cases were treated with the decompression, as you said, the foramen decompression. I haven't seen any case for the stabilization. It's very interesting. And I have a question. If the patient has no neurological deficit, no basilar invagination, only Chiari, would you do the same, the stabilization? And another question, second, from what age you start to proceed the stabilization? I mean, if there is a children, from what age you started to do the stabilization, and what complication do you have? Thank you so much.
So, first question, yeah. So if they've done a scan for something, I'm sure they will have some complaint. Sometimes they only have neck pain, and neck pain is an important symptom of Chiari that indicates mechanical instability. So if the scan has been done even for neck pain without any neurological deficit, then still you should go ahead and treat it. So neck pain is a big indicator of atlantoaxial instability, a mechanical problem. Then secondly, tell me?
Yeah, second, I mean, from what age you can proceed the stabilization surgery?
See, other thing is, before Abhida completes, let me complete this. Chiari malformation is a progressive symptom. Progressive. It starts with little bit neck pain, then more neck pain, then finger tingling paresthesia in the fingers, then weakness in the hands, then tingling paresthesia in the legs, then stiffness in the legs. Then it grows, and then there is a difficulty in talking, speech disturbance, sleep apneas, difficulty in breathing, and it goes on slow, progressive, relentless progression over several years, maybe over 10, 15, 20 years. And ultimately, it leads to miserable death. Chiari malformation, untreated, can lead to misery. So if you can do a good fixation with marginal symptoms like only pain, little bit neck pain, little bit stiffness of the muscle, if you have the experience of doing good fixation, it is better to do early fixation. Of course, if there are no symptoms at all, you might just like to observe the patient, but it is better to do fixation early. And also, we have done children atlantoaxial fixation in 3-month-old children, in 6-month-old children, in less than 2 years, at least 30 or 40 children, less than 2 years, we have treated. So this can be done early. Of course, Chiari malformation is not present in children so much. Pediatric population, Chiari malformation is less frequent. Chiari malformation is present usually in 3 or 4 or 5-year-old children, not in 1-year-old or 2-year-old. So if there is Chiari malformation, and in children, the symptoms are more pronounced. In children, sleep apnea is very much more pronounced. Voice disturbance can be pronounced. Breathlessness can be there. Difficulty in playing, difficulty in running, and breathless are more pronounced in children, in pediatric age population. And to do fixation, the recovery also is remarkably fast. So in pediatric age population, you cannot ignore Chiari malformation. You cannot ignore.
Thank you so much. And probably you have said about the forceps on the head, like the kids. We have probably the same situation in Ukraine. So this is mechanically, I totally agree with you. This is mechanically trauma, like for the Chiari thing. And one last question about the complications. Do you have much complications?
Complications can come. You see, this operation can give new life. It can completely change the person. And if you do it properly, if you do it nicely, precisely, anatomically, you give new life. If you don't do it properly, you can kill the person. So there can be huge complications. So it can be this side or this side. So you better be on this side, because complications can be dangerous. You have to learn the technique very nicely and properly. Atlantoaxial fixation is a big operation. It is a major operation, and it is an absolutely result-oriented operation. We have to learn and do it properly.
Thank you so much. Thank you so much.
Maybe you can read Professor Arthur Goyle paper, please. So many papers published. Sharon?
Sharon, you're muted. Sharon, you're muted.
Thank you very much, Abhida, for such a fantastic presentation. And thank you, Prof. Gold, for always continuing to help us to think out of the box. I think that's very important. As we grow, we don't want to stay. We want to keep progressing. So as I talk about progress, I think our next presenter, we'll move on to our next presenter, which is Professor Manubu Tamura. Professor is a professor and chairman in Department of Neurosurgery, Yamaguchi, University School of Medicine, Yamaguchi, Japan. And today, he will speak on surgical strategies for Moyamoya disease. Professor?
Yes. Can you see my first slide?
Yes, we can.
Okay. Today, I would like to talk about surgical strategy for Moyamoya disease. This timeline shows important works on Moyamoya disease. The concept of the disease was established in 1969. Suzuki and Takaku reported 20 cases with bilaterally progressing narrowness of the carotid fork and abnormal net-like vessel picture. They described it as Moyamoya. As you know, this disease name and staging are still used worldwide today. At that time, initially, direct bypass was used to undergo for this disease. This is the first report of STMCA for Moyamoya patient. The experience neovascularization was observed at the surgical site. It led to the development of the indirect anastomosis technique. In the 1980s, various indirect bypass surgery were introduced. Among them, EDS is our original method, so I would like to briefly introduce this method. In surgical dissection, the dura is a two-layered structure. The meningeal arteries are running in the outer layer. It is called periosteal dura. This paper shows the method of split dura. This is from our institute. This split dura is an additional surgical technique. For example, after EDAS, as shown in this figure, another site of the dura in the craniotomy is opened and dura is split and just sutured. These are the DSA images of a pediatric patient who underwent STMCA direct bypass and EDS split dura. The figure on the left shows preoperative lateral image of ECG, and on the right shows 1 year postoperative image of ECG. As you can see, the STA with direct anastomosis has developed. But the development of the MMA is even more remarkable. Preoperative is this, and after operation is MMA is this. And you can see the growth of neovascular vessels from MMA. From this image, we can know the effectiveness of split dura. I would present our combined bypass, STA MCA and 𝑒DAS and split dura. This is adult ischemic onset Moyamoya patient. We usually perform craniotomy as to protect MMA like this. STMCA direct bypass is nothing special. This case, we use frontal branch of STA for direct bypass. The patency is confirmed by ICG video angiography. And then, using the STA parietal branch here, we perform 𝑒DAS here. And then EDS split dura is added. This is 4 times faster speed. As you can see, inner layer of dura is easily dissected. This method is very easy and it takes only a few minutes. Moreover, it is very effective for neovascularization. So I would say, please try it once. Split dura and just suture the dura. After suture, we use dura wave and fibrin glue to close the dura. EGS and multiple bar hole are also useful approach. The effective neovascularization has reported even for adult Moyamoya patients. It may be useful for ACA territory revascularization. We have to think about how to operate the Moyamoya patient. For pediatric patients, as this meta-analysis, no difference in efficacy in prevention of stroke between combined bypass and indirect bypass, and also no difference between direct bypass and indirect bypass. In angiographic outcome, combined bypass is superior to indirect bypass. These results indicate for pediatric Moyamoya patients, indirect dominant combined bypass surgery may be reasonable. On the other hand, for adult Moyamoya patients, as this another meta-analysis, all the methods were equally effective for prevention of early stroke. But for prevention of late stroke and late hemorrhagic stroke, direct bypass and combined bypass are better than indirect bypass. These results indicate for adult Moyamoya patients, direct dominant combined bypass surgery may be reasonable. At the end, I would like to talk about JAM trial and AMORE study. The effects of revascularization for Moyamoya disease is improvement of CVF. Improvements of CVF prevent not only ischemic stroke, but also hemorrhagic stroke. This has shown by JAM trial. Sub-analysis of JAM trial has shown they divided anterior and posterior type by hematoma location and analyzed. The figure on the right shows regarding prevention of late hemorrhagic stroke, greater benefit of bypass surgery in posterior type. There were surgical indication only for ischemic onset Moyamoya patients, but now even in hemorrhagic onset Moyamoya patients, there are surgical indications for posterior type. And then, how about asymptomatic patients? We usually do not operate. At last year, Kuroda reported the 5-year result of AMORE study. This study is a prospective cohort study of asymptomatic adult Moyamoya patients. They observed 109 patients, 5-year follow-up. 7 patients developed stroke, 6 hemorrhagic stroke, and 1 ischemic stroke. The incidence of stroke was 1.0% per year per Moyamoya hemisphere. This is almost the same as rupture incidence of unruptured aneurysm. They also reported predictor of stroke were colloidal anastomosis and microbreath. So there may be surgical indication for asymptomatic Moyamoya patients with these risk factors. So now, with case selection, bypass surgery may be indicated even for asymptomatic Moyamoya patients. In summary, role of revascularization for Moyamoya disease is improvement of CVF. This means prevention of ischemic and prevention of hemorrhagic stroke. Regarding method of revascularization, combined surgery is reasonable, and especially for pediatric patients, indirect dominant combined bypass is reasonable, and for adult, direct dominant combined bypass surgery is reasonable. Revascularization may be indicated for selected asymptomatic patients now. Thank you for your attention.
Thank you very much, Professor Tamura. Very concise and precise, and a good summary of treatments for Moyamoya disease. So I will open up the floor now for questions. I think we can take our question. How about Professor Ishihara? I'm sure you have some comments.
Ishihara is me.
Yeah. Would you like to give some comments?
Now I presented.
Oh, you presented. Sorry. Then I presented you as professor. I'm very sorry. Yeah.
Sharon, you made a mistake because he is Ishihara,
Because
not Tamura.
The flyer given to me was
Sorry.
Yes.
Okay.
My apologies to Professor Ishihara. Yes, thank you very much. That was very good presentation.
problem.
Yes. Do we have any questions?
So Ishihara Sensei, thank you very much for your great talk. ありがとうございました。So is it easy to understand to some choroidal anastomosis for everyone? By angiography.
Yes. Can I use my slide again?
Yes, sorry for that. Because that is a good indication for asymptomatic cases.
Yes. Choroidal anastomosis like this. Moyamoya vessels. There are some many Moyamoya vessels, but especially the related anterior choroidal artery pathway. For example, this one is like this. This collateral channel patient with such cases are very high risk of stroke.
So APBU is a left side A indicated in the
Indicated.
APBU.
APBU is this. You see here.
So that's a good indication for maybe the surgery, maybe. Or
Even in asymptomatic cases from this study.
Thanks so much.
I want to know from you, who has described this 𝒂𝒐? And you said that there was some anastomosis at the surgical site, some intracranial, extracranial anastomosis. This was identified. Who identified this? Because this is such a wonderful identification that you put the muscle, you put the artery on the skin, on the brain, and there is a revascularization. What is the mechanism? How this revascularization means how this, anastomosis can happen without anastomosis? Anastomosis without anastomosis, without suturing. And also in Suzuki's grade, as you mentioned, Suzuki's grade 5, grade 6, there is so much natural anastomosis. Or extracranial, intracranial, so many, you will see 20, 30 anastomosis by, automatic natural anastomosis. You think, do you think that if there is a possibility that there can be natural anastomosis, you think human anastomosis is necessary? Is absolutely necessary, or it is not necessary, or can be avoided?
Sorry, I didn't completely understand, but I think I show the structure of the dura inner layer protect neovascularization extracranial to intracranial, and initially many surgery, for example, drainage or direct bypass, and they found the neovascularization from the surgical site. So and then actually, for example, we operate direct surgery, but 1 year or 2 years later, we perform angiography. Indirect bypass is dominant to supply the cerebral blood flow sometimes. So, of course, it depends on the patients, and younger patients has more neovascularization, but even in adult patients, indirect bypass is very useful, I guess.
ゴエル先生の質問は、まず、イーダスは誰が言い出したのかっていうのと、
いいです。
二つ目はですね、吻合してないのになんで血管が頭の中に入っていくのかっていう、それはどうしてですかっていうことですね。
Sorry. I misunderstood. EDAS is,
松島先生ですかね。
松島、yes. 東京メディカル、東京メディカル、University, maybe 1980s, Professor, 何でしたっけ？
松島？
プロフェッサー
松島。なんで置いただけで。
And it is clearly understood, but in Moyamoya patients, their cerebral fluid, basic FGF or some such factors are they have, so maybe the brain is chronically ischemic, so brain secrete such factors. So neovascularization is
も
made.
う一回先生、ファクターの名前をもう一回言ってもらっていいですか？
Basic FGF. Maybe 𝑉𝒐𝒓 is also. There are some papers.
So there is a natural anastomosis by nature, by
Nature.
you see, you put the muscle on the brain, there is anastomosis with the MCA. You put the STA on the brain, there is STA-MCA bypass done by nature. So this is a very fantastic phenomenon. Which is
Yes.
difficult to understand as to why and how this anastomosis occurs in Moyamoya patients.
Yes.
And whether this kind of anastomosis can be used in stroke patients, like ischemic stroke, to prevent stroke, prevention of stroke. You can put STA on the brain or muscle on the brain, and there is, some kind of anastomosis, and there is no stroke. Is this a possibility or not possibility?
It has a possibility, but for atherosclerotic occlusion patients, there are no possibility. Usually, they don't have neovascularization. Only for Moyamoya patients now.
I think here we can see, like Prof. Goel, what Prof. Ishihara asked earlier. Basilar invagination is common in, I think, in India, whereas I think Moyamoya is a very common in East Asia. I think in South Asia it's more of cerebral venous thrombosis. I think we see more.
Yes.
We don't see so much in East Asia. Whereas East Asia, I think Moyamoya is a very common disease. Yeah. So it has also to do with other reasons, genetic maybe. Yeah. So any other comments from anyone? Abida, would you want to say anything?
A nice presentation. Insights into Moyamoya disease.
Yeah, I think because all of us we don't see Moyamoya so common in our setting, maybe.
We do see, but not to this extent. We do see a lot of pediatric patients.
That's correct.
Yeah.
So I think Ishihara Sensei mentioned about Amore study. That is a very recent one. So incidental one. So encounter so many cases, incidental Moyamoya vessels. So that is he mentioned about the two point. That is a good indication for surgeries.
Yeah, I think
𝑫𝒊𝒔𝒆𝒂𝒂, thank you so much.
thank you so much. Yeah, that one gives us a new insight. I think so we won't be so conservative. At least now we know the indications.
Yeah.
Thank you very much. So, Professor Kato, you want to say anything? I think we have finished
is
all
fine.
our three speakers.
Because yeah, I thank very much Dr. Atoy-Goel, because he leads us.
Yes. Thank
Especially, yes, his the life work of the adult axial instability. That was a great lecture by Abhidasha. Thank you so much.
Thank you everyone for joining us this evening. I'd like to thank our three speakers, Alexandra, Professor Abhidasha, and Professor Ishihara for giving us insightful insights into different things in neurosurgery, different subspecialties. So thank you all for joining us today. We will hope to see you all again in a month's time. Take care, everybody, and have a good night.
Okay. Arigato. Thanks so much.
Thank you.
Atu, thank you very much. Abhida, thank you.
Bye bye.
Moira.
Moira is here, Professor Kato.
Yes, I know. Yes.
Yes.
So,
Yeah, hi. Thank you very much for.
Hi. Okay, so you learn a lot from
Okay.
Abhida, okay?
Thank you very much. Bye bye.
石原先生、ありがとうございました。
ありがとうございました。
どうも、お疲れ様でした。